Okay, so this is chapter 4 from the textbook of radiographic positioning and related anatomy, the 11th edition. This is actually a separate recording for wrist. So we will begin in the book and chapter 4. For a routine wrist, the views that are included in that would be a PA wrist, a 45-degree lateral oblique, and a lateral wrist. And the technique is just as it was for hand, 65 kVp at 1.2 mass. Some of the specialty views included for a wrist are the ulnar deviation or the modified stecher. You can also have the carpal tunnel view and the carpal bridge as well, and we'll look at that when we get a little farther on. The carpals, this picture is actually on page, hold that thought, this is the posterior view of the carpals. This is figure 4.5 on page 126. So in the proximal row we have scaphoid, lunate. Scaphoid is boat-shaped, the most commonly fractured carpal. Lunate is shaped like a moon, triquetrum, the pisiform, and in the distal row we have the trapezium, the trapezoid, the capitate, and the hamate. The capitate is the largest carpal bone of all 8. The anterior view of the carpals, this correlates to figure 4.6 on page 126 as well. They are showing you can see first through 5th digit. So this would be thumb side. So this is radius, this is ulna, and then you can see how the bones are in that view as well. There are a couple mnemonics for the carpal bones. If I'm being honest, this one not really sure of that. This Steve left the party to take Carol home. This is the proximal row, and this would be the distal row. So Steve left the party to take Carol home. The PA anatomy of the wrist, this correlates to figure 4.8. You can see that all of these, this is first digit, second digit, third, fourth, and fifth. So this would be radius, because radius is always thumb side. This is ulna. This one right here is the scaphoid, the lunate, the triquetrum, and the pisiform. And then you've got up here, letter E is the trapezium, the trapezoid, the capitate, which is the largest, and then the hamate is H, and the hamate has a hook on it, and that is called the hamulus. The hamulus is the hook of the hamate. This is ulnar deviation, one of the specialty views that we do for the scaphoid. This actually correlates to figure 4.1 on page 127. You can see that with this ulnar deviation, you are literally pushing the wrist towards the ulna, which is on the 5th digit side. You're kind of bending the wrist outward for that particular view. Carpal canal. This is figure 4.11 on page 127. They are labeling thumbs, so that would be first digit, second, third, fourth, and fifth. And then you can see the scaphoid here is letter A, partially superimposed with the trapezium and the trapezoid in this picture. Lateral wrist, this is figure 4.12. This is actually perfect lateral. You want the radius and ulna directly on top of each other. You want them to be superimposed just like that. This is a very, very good positioning of the lateral wrist. That's our goal every single time. The radiocarpal joint, this is, let's see, radiocarpal. I'm trying to correlate the page for you. Radiocarpal joint, this is on page 131. Okay, the radiocarpal joint is a diarthroidal. So the wrist joint itself is ellipsoidal and is the most freely movable or diarthroidal of the synovial classification. Only the radius actually articulates directly with two carpal bones, the scaphoid and the lunate, and this radiocarpal joint is the wrist because it's where the radius and the carpal bones meet one another. So the radiocarpal joint. And this particular picture is figure 4.22 on page 131. The wrist movements, there is ulnar deviation, which is done for the scaphoid bone, which is the most commonly fractured bone, and it is boat shaped, B-O-A-T. And then there is radial deviation, which can demonstrate the lunate, the triquetrum, the pisiform, and the hamate. So this is radial deviation going towards the radius, and this is ulnar deviation going towards the ulna. The fat stripes on the wrist, these can be found, they talk about the fat pads and the fat stripes on page 133. So you have the scaphoid fat stripe, which they're showing you right here. And then we also have a pronator fat stripe, which is B. Now the fat stripes in the wrist, typically the fat stripes are only seen when they're considered a positive fat stripe sign. And typically if there's injury, either a fracture or significant displacement, then the fat stripes are visible. We also have fat pads in the elbow joint. When they talk about this, there's certain accumulations of fat, and they're either called fat pads, fat bands, or fat stripes. So displacement of a fat pad or a fat band can be the only indication of the disease process or significant injury in a joint region. Okay, so these are typically seen. Now, it's not our job to find them, but once you see them, it's kind of hard to unsee them, and you tend to start to look for them more and more. The PA wrist projection. This is the first of our routine images on a wrist. This is actually on page 151, and this figure here correlates to 4.86. This would be done for any fractures of the distal radius or ulna, any pathologic processes like osteomyelitis or arthritis. Your SID is 40-inch to tabletop, and you would be collimated minimally to an 8 by 10, and then you would collimate beyond that so that you were just beyond skin line. The elbow should be flexed for the first 3 views of the wrist, meaning the elbow should be at a 90-degree angle for the PA, the 45-degree lateral oblique, and the lateral. There is a specialty view that we will show you that Advent Health does. And for that one, you do have to extend the arm in order to rotate the wrist in the direction that is needed. So when you flex the elbow 90 degrees, it will flatten out the wrist. It doesn't necessarily say that in the book, but it is a good idea to flex that wrist to get the carpals as flat as you can. You want to arch the patient's hand slightly to reduce the OID in the carpal area. And on this, you do have to include the distal 1/3 of the radius and ulna. Now, the technique on this, we said, is exactly like it is on the hand. So you're at 65 at 1.2 mass. Patient sits at the end of the table, elbow flexed 90 degrees. They would just have their hand down on the IR with their fingers slightly arched to reduce the OID, and the central ray is mid-carpals. They do show an alternative AP wrist that can be done if the patient cannot put their hand PA. Um, a lot of times this can be done if you're trying to get the intercarpal spaces closer to the IR. It would work if the patient wasn't able to do PA, but PA is protocol in most facilities. The AP would only be done if absolutely necessary. The marker would still go lateral to the part like it did for hand. So if it's a right wrist, it would go towards the fifth digit side so that when it hangs to the right of the image. The evaluation criteria on a PA wrist, you do have to have at least 1/3 of the distal radius and ulna. You have to have mid-metacarpals and proximal metacarpals, all the carpal bones, distal radius, ulna, and all the joints associated with that. Okay, so you need 1/3 of distal radius and ulna for this particular image. Moving on to the next image in our routine, this is a 45-degree lateral oblique wrist. This is on page 152. We're still at 65 at 1.2, still collimated minimally to an 8 by 10. The elbow would still be flexed, still at a 40-inch SID to tabletop. And what you would do on this, remember every oblique is going to need a degree of rotation and a direction of rotation. So from the PA, the patient would simply roll their hand away from midline to a 45-degree angle. They do show a sponge in this particular picture, but most of the time, especially a sponge like this, you are not going to be using that because there's no way to clean that. So it's best to learn to just have the patient roll and try and keep their hands straight at a 45-degree angle, and remember the elbow is flexed. Your central ray is still mid-carpals, and your marker would still go lateral to the part on the fifth digit side for this particular image. Assuming this is done correctly, again, you'll see at least 1/3 of the distal radius and ulna, all the carpal bones, at least to the mid-metacarpal area. This is actually a good 45-degree lateral oblique wrist. You can see that the metacarpals are slightly superimposing, especially in here because the wrist is at a 45-degree angle. The last image in a routine wrist is a lateral medial projection. So again, if you go back to anatomic position, this portion right here is lateral in anatomic position. So as far as the projection, it's going from lateral to the medial side down on the bottom. So it's a lateromedial lateral. This typically is the 90-degree angle from the PA, and this can demonstrate any fractures or dislocations of distal radius and ulna. Specifically any anterior fragment displacement for a Barton's fracture, a Colles fracture, or a Smith fracture. Still 40-inch SID to tabletop, still 65 at 1.2, or collimated to the part size, ideally smaller than an 8 by 10, so you wouldn't change your collimation between these images. You would just keep it what it was and potentially have to alter just a little bit to fit your marker. Patient's elbow is still flexed, and you want their hand and wrist in a true lateral with their fingers extended, just like they're showing you here. And this picture is 4.94 on page 153. This is from an older edition, but it's similar to 4.95 on page 153 as well. Central ray is still mid-carpals in the middle of the carpal bones, and you're still going to get at least 1/3 of distal radius and ulna, all the carpal bones and mid-metacarpals. So you can see mid-metacarpals, nice lateral wrist, radius and ulna are superimposed directly on top of each other. And in this case, the left marker was not placed there but annotated. But if it were placed as it should have been, that would be to the left of the part on this left lateral wrist, which would be acceptable. This is the Advent Health additional view. Now, this is not in your book. This was a separate handout that I gave you. There is no real name that I can seem to find for them to call this. So basically, when we were in a lateral, we were at 90 degrees. And this actually rotates the hand and the wrist back 45 more degrees. So we have begun to call this the 135-degree lateral oblique, and it is done to demonstrate the pisiform. Okay, so on this particular image, this is the one where you would have to open up or extend the elbow. It is impossible for most patients to have the elbow flex 90 degrees and roll that wrist backwards 45 degrees. So they would extend their arm out, roll their whole forearm and wrist out 45 more degrees. So from lateral, continue to rotate laterally 45 additional degrees, and that's how from 90 with 45 we get the 135-degree lateral oblique. And it demonstrates this is a fractured pisiform. You can see here, and this particular view does an excellent job of demonstrating that. And this is typically in the Advent Health protocol. Special projections of the wrist, there are two that demonstrate the scaphoid specifically. That is your PA and PA axial with ulnar deviation and the modified stecher method. Now both of these are on page 154 and 155. And then we also have two tangential views. Tangential means skimming a part. So the tangential views are typically done for the carpal tunnel or carpal canal. That's the Gainer Hart method on page 158. And then there is the carpal bridge, which is on page 160. Remember, the scaphoid is the most commonly fractured carpal bone. So the PA axial scaphoid, this is the picture 4.98 on 154. You can see that there is ulnar deviation in the patient's right wrist. So this demonstrates fractures of the scaphoid. And then what we do with this is the patient is seated, you position the wrist like you were doing a PA, but then you evert the hand, moving it towards the ulnar side as far as the patient can without lifting or moving their arm or hand. Your central ray, which is demonstrated always by this pointer, is angled 10 to 15 degrees proximal or towards the elbow, and it's going to enter the scaphoid. Okay, the scaphoid is right here. It's easier to show you in class. Sometimes they'll call that the snuff box. If you lift up your thumb, if your hand is flat, you see a little indentation towards your wrist when you lift up the thumb. That is typically where your scaphoid is. And if this is done correctly, then it kind of highlights the scaphoid. It's clearly seen without any superimposition. It's not foreshortened, and this is figure 4.101 on page 154. So this is a PA axial with ulnar deviation. Remember, axial implies angle of more than 10 degrees. So it's PA axial, 10 to 15 degree angle, and ulnar deviation as well. This is the modified stecher method, and truly the only thing that changes is instead of angling the tube 10 to 15 degrees, you actually put the patient on a sponge to compensate for that angle. Okay, so we're at a 40-inch SID, collimated less than an 8 by 10. Your technique would still be 65 at 1.2 for all of these specialty views. And you put the hand and wrist on an elevated 20-degree angle sponge. And then you would have the patient attempt to evert or turn their hand towards the ulnar side. If they cannot, that's okay, but if they can, um, that would demonstrate the scaphoid even better. And notice you can see central ray here. Central ray is perpendicular to the scaphoid. So the only real difference between the PA axial with ulnar deviation and the modified stecher is the central ray angle is angled on the PA axial scaphoid, but on the modified stecher, you don't angle the central ray, it's perpendicular. You angle the hand by utilizing the sponge under the patient. So both of those views are to demonstrate the scaphoid. So this one is the hands elevated with ulnar deviation, but again, no central ray angle. This is 4.104 on 155. And this is with the hand elevated on the sponge, but no ulnar deviation or central ray angle. So you can see this one just kind of makes it look a little bit better. It's completely not superimposed. You can go all the way around this. This one is okay. It's not as good as this one, but if the patient cannot ulnar deviate, that's perfectly acceptable, and that often is the case when there is a wrist injury. The carpal canal, this particular view is also a specialty view. This is on 158 of your book. This correlates to figure 4.111. So the carpal canal is a tangential infrasuperior projection. So tangential means skimming. Infrasuperior means that the central ray is going through the inferior and exiting the superior. This is the Gainer-Hart method. Okay, you don't want to do this if the patient has any wrist trauma, obviously, but you would place the patient's wrist on the IR. You would ask the patient to hyperextend their wrist or dorsiflex as far as they can. Ideally, you're trying to get this 90 degrees to the IR. You want their fingers and hand perpendicular to the IR. And the central ray, you can see right here, is angled 25 to 30 proximally to the long axis of the hand, and the central ray enters 1 inch distal to the base of the third metacarpal. Okay, so it would be going in right about here. I'm not sure why they have it all the way over here, but when that is completed, you can see on figure 4.112, this one is obviously labeled, this one is not, but they're looking in this area right here in the carpal tunnel or the carpal canal.